Professor Dr. Hisham Hamoud for his kind invitation for me to participate in this conference, and thank you for all members of Scientific and Organizing Committee. Today, I will talk about pediatric osteoporosis. We know this is a common and very important issue in adult and postmenopausal women, but of course, it occurs also in children, but a little quite it is different from adult in terms of definition, causes, diagnosis, monitoring, treatment option. The definition of osteoporosis in children defined by the International Society for Clinical Densitometry, they define osteoporosis as the presence of clinically significant fracture or a significant fracture history with low bone mineral density. And the clinical significant fracture history is one or more of the following: long bone fracture of lower extremity, vertebral compression fracture, two or more long bone fracture of upper limbs. And low bone mineral density means BMD z-score less or equal to -2. Recently, in the update of the International Society for Densitometry, they added a two statement to a new definition of osteoporosis in children. First statement was the finding. Oh, I'm sorry. اوكي كده الصوت كويس؟ Okay, the first statement كانت the finding of one or more vertebral compression fracture is indicative of osteoporosis in the absence of local disease or high energy trauma regarding the BMD on this score. And the second statement was, in the absence of vertebral fractures, the diagnosis of osteoporosis is indicated by the presence of a clinically significant fracture and -2 or less z-score. This clinically significant fracture defined by 2 or more long bone fracture by age of 10 years old, or 3 or more long bone fracture at any age up to 19 years old. So let's go to the risk factor and the causes. We know that osteoporosis in children may be primary or secondary. Primary due to genetic causes, like most commonly cause is osteogenesis imperfecta, and a long list of secondary causes and risk factors. The most two important and encountered for us as an adult rheumatologist is the chronic rheumatic diseases and treatment by glucocorticoids. So let's focus in this group of patients that's a high risk factor or has secondary osteoporosis due to chronic inflammatory rheumatic diseases or treated by steroid. The risk factor in those patients are active inflammatory disease, glucocorticoid, decreased mobility, malnutrition, inadequate calcium and vitamin D, decreased sun exposure, especially for the lupus and overlap and related syndromes, decreased height and weight, and pubertal delay issues. We know what we call the Mechanostate Theory, that is very important in a child because this is guarantee a development of a bone strength in a childhood. This is mean that we need muscle strength induced by physical activity and movement, and this is leading to this mechanical load leading to more bone density in the children. So in the children of rheumatic diseases, we have two potent risk factors. We can interfere with this mechanostate model. We can anticipate first the glucocorticoid therapy, and second risk factor is the loss of muscle strength due to the joint disease and immobility of these children. And not to forget also the pro-inflammatory cytokine in these diseases, as Dr. Ahmed in the first lecture, it was very informative lecture. He detailed this, how the immune system is related to the osteoporosis. So how steroid causing osteoporosis in children? First, steroid leading to a negative bone balance, more effect on the of inhibiting the bone formation more than inducing the bone resorption. Number two, the effect of steroid specifically for the trabecular bone. And we know that the spine has 2/3 of the content of the spine is mainly trabecular bone. So it is not surprising that we see more of fracture of glucocorticoid induced osteoporosis, mainly vertebral fracture. Number three, steroid causing what we call differentiation of the bone marrow stem cell into adipocyte, and it causing a disruption of the osteocyte canalicular network leading to a micro damage. and also steroid reducing the synthesis of type 1 collagen and osteocalcin, leading to a weak bone matrix, and not to forget the extraskeletal side effect of steroid on the GIT, leading to decreased absorption of calcium. Fortunately, in the past 2 decades, there is an increasing in the use of the DMARD, specifically the biological DMARD, and this leading to less depending on maintaining our children on high dose or long-standing dose of steroid. So this is associated with, luckily, with decreased incidence of osteoporosis in pediatric population. So for diagnosis and assessment, of course, X-ray conventional is the most common used diagnostic method in diagnosis of osteoporosis. But unfortunately, if we wait till we have osteoporosis diagnosed by X-ray, this means that the child lost at least 30 to 40% of his bone mass at the time osteoporosis detected on conventional X-ray films. So the most specific and the golden method for diagnosis osteoporosis and more earlier than conventional CT, of course, it is the DEXA scan. And we, due to bone density varies greatly with age, we know that we use this score in the pediatric population. But there is an update in the past few years that we are shifting now from using or depending on the PMD using the DEXA to assess the risk for fracture in those children to a new approach which focus on assessment of the clinical history risk factor and the fracture identification in children. This is the different method for bone density measurement. Of course, the DEXA, which is the golden standard, as I said, and in the update of International Society of Clinical Densitometry, they added the use of proximal femur and distal lateral femur and 50% of the radius. The other two new method for diagnosis of for measurement of PMD. Number one is the peripheral quantitative CT, and this is I think this is more important than DEXA because it adds a value that's not measured by DEXA. It measures the volumetric density, it measuring the trabecular and the cortical thickness and the cortical area. This all give a better impression on the bone quality in the children. And most recently, ultrasound, of course, non-invasive and very quick, but I think still we need more data on using ultrasound in measuring bone mass density. Because I said vertebral fracture is very common in glucocorticoid steroid-induced osteoporosis. Of course, it is a hallmark of the disease, and usually it is asymptomatic. So it is preferred to use the DEXA vertebral fracture assessment because it gives a better image and better quality than the conventional X-ray. And we have a classification for this vertebral fracture as percent by the reduced height of the vertebrae, either anterior wedge or by concave fracture, or the crushing fracture on the posterior part of the vertebrae. And we are estimating the ratio of this general classification by, as you see here, X. The ratio is X to H. For the anterior wedge fracture and for biconcave, and for the posterior crush fracture, we are the ratio is calculated for, in relation X to the height of the posterior vertebrae, the adjacent vertebrae, the upper one and the lower one. Another method we used in diagnosis of osteoporosis, which is the bone turnover markers. It is used commonly in adult, but in pediatric population, it is limited, of course, because due to high skeletal growth velocity and rapid turnover in children. For prevention and treatment, why do we care? Why we wanted to prevent osteoporosis and treat it and monitor? Because 90% of peak bone mass is achieved in the teenage by the age of 20 years old. This bone mass peak accounts for at least 60% risk for adult fractures. So childhood diseases and medications like steroid can interfere with this achieving of normal peak bone mass. So we need to prevent osteoporosis before it's happened. merely depending on knowledge, our awareness about the main risk factor for osteoporosis in pediatric rheumatic diseases, and knowing these risk factors, and be aware about the good nutrition and good diet, and giving good supplementation of calcium and vitamin D, and encourage physical activity. Let's focus first with the physical activity. It is very important to encourage this and encourage the exercise program. This is from studies that proved that short-term exercise program 3 times a week for 12 weeks results in significant PMD increase in juvenile idiopathic arthritis patients. And of course, this is the doses for supplementation of calcium and vitamin D according to age. And if we have a vitamin D deficiency in any child, we should treat it by this one of these two options, first 2 weeks, and this followed, of course, by a maintenance dose. And a very important point for prevention of osteoporosis, of course, treatment of any underlying chronic diseases and activity. If the patient have inflammatory rheumatic diseases, of course, it is a very important point in prevention of osteoporosis. Before discussing the treatment of osteoporosis, pediatric osteoporosis, 2 points are very important to know. Number 1 is treatment of a low PMD in absence of fracture is not advised. Just careful monitoring of at-risk children for the early sign of osteoporosis, including vertebral fracture, will identify who of them will need a bone target therapy. The point number 2 is that the potential of the children to spontaneously do what we call vertebral reshaping and restitute bone marrow density following transit threat to bone health. Let's give a more definition for what we call vertebral reshaping. What I mean by vertebral body reshaping. Let's see this example. This is a girl and she is 7 years old. At this time, she was diagnosed as dermatomyositis and started steroid. As we see, her spine is normal. 2 years later, she is in steroid and she started to have anterior wedge fracture. 2 years later, she is on steroid and already she was started 2 years bisphosphonate, and she has improvement of the height of the anterior vertebrae, as you see at L1. And 1 year later, she stopped the steroid, she stopped the pamindrate, but still she is gaining more height in the vertebrae, which was widget at the age of 7 years old, as we see here. And even after further stopping of steroid and not using any bisphosphonate, the child can retain the normal shape of vertebrae. This is called vertebral reshaping, and this is unique for children. Of course, it doesn't occur in adults. And even without any treatment, the child can retain this vertebral reshape and back again to the normal vertebral shape without any treatment, as we see here in this example. This child stopped the steroid at 2 years old, and at 10 years old, she has a normal vertebrae. So we can conclude that bone target therapy for children will be reserved for 2 options, for 2 conditions. Number 1, significant impact on fracture or quality of life. The child has severe back pain, severe immobility, or interrupting the extremity fracture or refracture cycle. And the second condition we should use a bone target therapy is a child with asymptomatic or very low or very mild symptom, but he has a persistent risk factor such as further vertebral collapse, decline in PMD parameter, recurrent extremity fracture, or an inability to spontaneously do vertebral reshaping. Of course, the main bone target therapy is bisphosphonate, widely accepted and tried in pediatric population, and we know that it has high affinity for the bone and improving PMD and improving the fracture outcome. And these are the different second and third generation bisphosphonate used in treatment of osteoporosis, primary and secondary osteoporosis. Niridronate actually used in exclusively in osteogenesis imperfecta associated osteoporosis. And this is the known adverse event. As we all know, the adverse effect of bisphosphonate as it happens in adult, but it is a little different in a child because we have a unique side effect that occur in more in children. This is the line. This is a horizontal line called zebra line. This is insignificant, non-harmful, and disappear by time. Other than the bisphosphonate, we have now ongoing clinical trials on denosumab and anti-sclerostin antibody and losartan on pediatric population and waiting for its results. We know that American College of Rheumatology have published in 2017 a lot recommendation for adult, but they included also the child. As we see here, they recommend initial fracture risk assessment only by clinical assessment and no further initial assessment needed. And on follow-up reassessment fracture also by clinical assessment, no further assessment needed. And this is the recommendation for a child with on steroid, 3 months or more, they should take calcium and vitamin D. And if they have an osteoporotic fracture or continuing on steroid by dose of 0.1 milligram per kg for more than 3 months, they should add biphosphonate. They recommend oral bisphosphonate first over IV bisphosphonate. Otherwise, we have a contraindication for oral treatment. And a new recommendation by ACR are in process now and will be published in late 2022. Another update about recommendation for treatment of osteoporosis in children. The Osteogenesis Imperfecta Childhood Osteoporosis Working Group have published 1.5 years ago this 51 recommendation, and they are classified into 8 categories. Number 1, the general recommendation, lifestyle and dietary habits, complementary tests and follow-up, prevention recommendation, and treatment recommendation and follow-up. And in the last category, they include some recommendation for treatment of corticosteroid-induced osteoporosis. مفيش كلام جديد, but I like to focus on 2 points in their recommendation. They said that treatment of calcium and vitamin D must be maintained even after stopping steroid by 3 months. And the last recommendation, they said that the lateral spine X-ray or PMD checking and DEXA are not recommended on routine basis for those children and adolescents being treated with inhaled glucocorticoid under dose of 800 microgram, unless, of course, they have another risk factor. And this is my conclusion. Most important conclusions as a prophylactic measure, the early diagnosis, monitoring, proper therapeutic approach are essential to improve the bone health, not only on the children and the adolescents with osteoporosis, but also in the adults. They will become in the very near future. And thank you very much.
Thank you, Dr. Mervat. كالمعتاد بسم الله ما شاء الله جديد presentation. The next speaker will be Dr. Prof. Nihad Shadbi, Osteoporosis Practical Essentials.
Bismillah ar-Rahman ar-Rahim. First, I'd like to thank Dr. Hisham Hamoud for inviting me to participate in the 16th ARUM. It's an honor to present my topic today in front of each and every one of you. Let's start my topic today from a practical point of view. من نظرة physician بيقعد في عيادة الأوستيوبوروسيس. Burden of osteoporosis. الحقيقه وانا بحضر التوبيك ده النهارده لقيت الايجيبشن ريجستري للاوستيوبوروسيس ما هياش اكيوريت اونلاين وما هياش افيلابل بالنسبه لي، فاضطريت اخد الريجستري بتاع USA. لقيت فيه ان 10 مليون امريكان over 50 years